Good afternoon, everybody. So, welcome to this session of the All India Ophthalmic Society on glaucoma surgery. And we have some of the top speakers from around the globe who will share the knowledge with us. And the first speaker is Dr. Keith Barton. I think he needs no introduction, the last word in glaucoma surgery from Moorfields, UK. And he'll be covering two very important topics. The first one is on uveitic glaucoma, and the second one is on minimally invasive bleb surgery. And I would like to invite Keith, and you can be comfortable and give both lectures back to back.
Thanks, Tanuj. I was just going to do them the other way around, so I'll now change that. Just give me a sec. Well, uveitic glaucoma, we got the slides, has been something, it interested me, but I was specifically asked to set up a clinic to look at the management of glaucoma and uveitis at Moorfields in 1996, because at that time it was of concern that the patients with uveitis who got glaucoma all disappeared into the glaucoma service, and their uveitis was not properly managed, and the trabs all failed and so forth. So we set up a clinic originally to try and manage the patients with uveitic glaucoma separately from the general glaucoma pool. And with time, that has gradually changed back again, because people are much more aware now about how important it is to control the uveitis. I have quite a few financial disclosures. The main one's a Paul glaucoma implant. Everything in uveitic glaucoma is more extreme than primary glaucoma. Uveitic open angle is more extreme IOP swings than POAG. Angle closure is more extreme than primary angle closure. The disease can elevate the pressure or reduce the pressure, and the treatment can elevate the pressure or reduce the pressure. So the mechanisms can be mixed and all over the place, and you need to clearly identify what's going on, and it's not one size fits all. One particular problem that's not uncommon is the management of angle closure. And then the other one is really the long term, taking the pressure out of the equation so that the uveitis specialist can manage the uveitis properly without fear of the pressure going out of control, because it's a very false economy to be reducing steroids just to reduce the pressure and then letting the damage get worse. This often entails surgery, and the glaucoma specialist must have the full range of surgical options at their disposal. You know, if you don't know, if you only do MIGS and don't have the full portfolio of glaucoma surgery, you're not going to be able to manage uveitic glaucoma properly. Angle closure, particularly just acute angle closure, which is less common, obviously, but particularly devastating in hot eyes. And it tends to get managed like primary angle closure, which is obviously much more common and is what people are more familiar with. And the problem is that angle closure in uveitis comes in several flavors. There's the acute pupil block type. There's chronic angle closure from nodules, neovascularization, membranes, and there's forward movement of the iris lens diaphragm. So you've really got pupil block, chronic angle closure mechanisms, and you've got the central AC shallowing mechanisms. And these are all a bit different in terms of management. It is worth pointing out that pupil block in uveitis is not the same as pupil block in primary angle closure, this is primary angle closure. It's bad enough, but the pupil block tends to be relative. Pupil block in uveitis is absolute. The pupil's secluded. The iris isn't just in contact with trabecular meshwork, it's in contact with the cornea, and everything's stuck. And if you don't manage this correctly, the patient will go blind very quickly, and it's not unusual to see eyes that are no light perception at 40 years old from this. This is very different from primary angle closure. Here's a case, a 33-year-old Chinese male attended Moorfields in 2009 with rapid reduction in vision in both eyes and severe pain. Corneal edema, iris bombay, multiple KP, lots of cells, and posterior synechiae with iridocorneal contact right up the central cornea and no fundus view. And of course, somebody laser or tried to laser PI him, and kind of you can see that the machine gunned the upper iris with laser holes, and in the left eye and the right eye they managed to get through just about, and they got the pressure under control. And then 5 weeks later, when his medication ran out, he was back in angle closure again. And this is a very typical story with laser PIs in angle closure in uveitis. And what you really need to do is a surgical PI, which of course looks very easy. You open the cornea and you take it out, and there's your surgical PI. But of course, this patient wasn't actually uveitic, and the uveitic ones are much more difficult. In this particular patient, this is the guy I was talking about, the iris is stuck to the cornea. You can mobilize it with viscoelastic and as much as you like, and it won't come out. You really have to spend quite a lot of time trying to get the iris free, because it's not relative pupil block. It's not just going to fall back. It's absolutely glued to the cornea. And sometime later, after quite a while, actually managed to do the PI. Great. Well, what's the difference between a surgical PI and a laser PI? Well, not much really. It's a little bit bigger, that's about it. But the whole point is that a surgical PI means you go to the operating theatre and there are other things you can do at the same time. It's not that the PI itself is any different. The problem is with uveitis is pupil margin stuck to the lens, the iris periphery stuck to the cornea. That's why laser PIs tend to be ineffective. And part of the reason is that there are broad adhesions between lens and iris. You know, there's no continuous space. There may be no space at all, in fact, behind the iris. There's iris adherent everywhere. And this patient had Bombay in 2 quadrants, not 4. And whenever I put in dilating drops, the pupil didn't dilate, but the Bombay reduced in another quadrant. So it's not a continuous space. There's tons of adhesions. So it's not surprising a laser PI doesn't work. Do you think a surgical PI is going to work if you've got the same problem? Well, it's not just the surgical PI. The point is you can do some posterior synechial-lysis, which in phakic eyes is generally reasonably easy. And for some reason in pseudophakic eyes, it can be virtually impossible and much more traumatic. So posterior synechial-lysis looks very easy here, but it's not always so easy. And you've got to be really careful, or you can really traumatize the iris. And when you do posterior synechial-lysis, you can never be 100% sure that they're going to stay broken and that it doesn't adhere again afterwards, which is the other problem. So posterior synechial-lysis is tough, traumatic, and of dubious benefit. But you're in there, so you might as well do it anyway, as long as you're not doing too much, causing too much trouble. But it's not like opening a stuck-down pupil at the start of phaco. The pseudophakic ones, as I mentioned, are much more, for some reason, the adhesions tend to be much tougher. And this is one reason why it may not be a good idea, because what happened here is actually just traumatized the iris root, which is completely unnecessary. So posterior synechial-lysis may be beneficial, maybe not. But you're still not finished, because in uveitis, in acute angle closure in uveitis, you may not have got permanent adhesions formed yet, but they're starting to form. And the iris is stuck to the trabecular meshwork, it's stuck to the cornea. And if you go in with viscoelastic and just gently tease it open, you may undo adhesions that are beginning to form that have not yet become permanent. This is not true goniosynechial-lysis, you're just viscoing it open. And this is probably the single thing that you can do with a surgical PI that differentiates it from a laser. And this may be the one reason why surgical PIs are better. The fact that you can actually just visco open the angle before the adhesions become permanent. So, acute pupillary bulk and uveitis, it's absolutely not relative. The iris is stuck to the cornea and trabecular meshwork. Sticky aqueous means that the angle doesn't open after iridotomy. Surgical iridectomy permits you to physically open it with viscoelastic to ensure it stays open. And back to this patient, 11 days later, the posterior synechia haven't quite formed again. But the angle, it's not all open, but he does have some open angle, which he certainly didn't have before. This is a very good example of why laser PIs are not such a good idea. You've got 3 patent iridectomies here, but in fact on gonioscopy, whoops, I haven't got the gonioscopy. On gonioscopy, the angle's still completely zipped. So this patient had 3 successful iridotomies that flattened the iris, but the angle stayed glued shut. I don't like doing PIs externally. This is my favorite technique because it gives you good visibility. It requires more nibbling. It's using the vitrectomy forceps and scissors, and you can actually see what you're doing very well. So what about chronic angle closure? I don't tend to do goniotomies. This girl had goniotomy in childhood for juvenile chronic arthritis, type uveitis, and she did end up with a tube 15 years later. But the point with her is she did not have synechia. This was goniotomy for an open uveitic angle. And Ho Ching Lin did a retrospective study many years ago of goniosynechiolisis and uveitis and found that PAS had a negative impact on success in her patients. So doing goniosynechiolisis is not a great idea. And by implication, canal procedures will be of no great value if there are synechia. I tend to use chronic synechial angle closure as a predictor of chronicity. So when you've got the patient and you're not sure whether or not they're going to have a long-term problem, whether it's a steroid response, then chronic angle closure tells you that you're going to have a long-term problem. This is a no-brainer. The final type is forward movement of the lens IS diaphragm, which is traditionally thought to be caused by, the classic causes are VKH and posterior scleritis, neither of which I've ever seen cause forward movement of the lens IS diaphragm. All the cases I've seen have either been too much gas, too much oil, a tight buckle, or phacomorphic. The actual classic textbook cases I've actually never seen. But the diagnosis is obvious, very shallow central anterior chamber. And the most causes are actually iatrogenic. And obviously the treatment is to fix the cause, and that's very different from pupil block. And when I was training, this was poorly differentiated. The diagnosis was often badly made. People would call it pupil block when it was aqueous misdirection, and aqueous misdirection when it was pupil block. And I think nowadays people are much more clued into this. So one of my former fellows, Sonia Bennett from New Zealand, actually, without any collaboration with me, published this paper in the BJO on the outcome of peripheral iridotomy in subjects with uveitis. And Gary Holland and I were very interested in this, and we wrote an editorial at the same time. And it was very interesting because she had looked at 2,366 subjects who attended uveitis clinic in Auckland, and they had 131 peripheral iridotomies with 486 eye years of follow-up. 111 YAG, 20 surgical. Median survival, YAG, 70 days. Surgery, 11 years. So I think that's pretty clear, and I've tried to explain why that might be, why surgical iridectomy is so much more useful than YAG in acute angle closure and uveitis. And I think the message is, don't treat it like primary angle closure. You really got to treat it aggressively, or the patient will go blind. The other thing that we do in uveitis is obviously take the pressure out of the equation. So you need to be more aggressive surgically than you would for POAG. And predicting who will need surgery and who's just got a steroid response that might go away is difficult. Evidence of permanent angle damage is a strong predictor of chronicity. That's obviously a no-brainer. You know, if your angle's damaged, you've got a chronic glaucoma problem, and it's not just going to go away when the steroids stop. If you get evidence of optic disc damage, and this is very different from primary open-angle glaucoma, where we tend to operate in people with bad glaucoma. In uveitis, they're young patients with very high pressures, episodic fluctuation. It can be difficult to make the call. The optic disc's often structurally normal, and you don't know what the future holds. And I will usually operate with high pressures in patients with virtually normal discs because you know it's not going to go away. And once you start to get early disc damage, you know you're heading for trouble. So you don't wait in uveitis until they've got advanced disease. You operate much more early simply because they have much worse prognosis if you don't get on top of it. And this is a typical patient with a trab who would have a trab on the left with very early disc damage, which you would never really be doing in primary open-angle glaucoma. So it's very different in that respect. So evidence of early disc damage. Surgery generally needs to be more aggressive. The younger patients, higher IOPs, higher risk of failure, and the stakes are higher if you don't get it under control. Certain types of uveitis have a higher likelihood of requiring surgery, especially those with some sort of infectious etiology. Herpetic, Fuchs, and the other infectious etiologies tend to be more chronic and more damaging. I tend to highlight Fuchs because it's often misdiagnosed, missed, and the glaucoma potential underestimated, yet it's got very characteristic clinical features, and it commonly causes recalcitrant glaucoma requiring surgery, and filtration surgery tends to be less effective. And this is a video I did with all the various clinical features of Fuchs that you can see on YouTube. But the point is, it's not just heterochromia. If you're aware of the clinical features, it's a very early, easy diagnosis to make. Yet I've seen so many patients over the years misdiagnosed. Cataract is the big confounder in the management of glaucoma and uveitis. And chronic inflammation is the other one. And this was a 16-year-old who was down to almost light perception in one eye from cataract and a pressure more than 40. And ophthalmologists tend to take the cataract out because that's 90% of what they do, but the pressure's 40. If you take out the cataract, the pressure's going to be 50. You need to deal with the glaucoma first. Don't just do the cataract because it's the only thing you know how to do. You need to deal with the glaucoma. These patients frequently need cataract surgery, but you really got to be realistic about the risk of severely uncontrolled IOP afterwards. And this is not so relevant nowadays, but this was a 1990s phaco trab when people didn't really get an understanding of how difficult these can be to manage. And if you get the pressure, if you do a phaco trab and the pressure's not right afterwards, you can end up with all sorts of a mess. Typically, trabs had a bad reputation in uveitis, and this was a paper from Moorfields in the early 90s showing poor success. And tubes tend to work better than anything else in uveitis. Tubes tend to work better in uveitis than they do in anything else, but you do have to be careful with using big implants in patients who have had uveitis from early childhood because they can go badly wrong from hypotony. But control of inflammation is everything. And with better management, when we did another audit of the uveitis in the late 90s, the success rate with careful case selection and careful control of uveitis was much, much higher. And I have done Zens and I have done pressure flows, and we've written both of these up. But overall, what I do when I'll do MIGs in those with mild glaucoma, I'll do trabs in those with severe glaucoma and no risk factors for failure apart from the uveitis. But overall, we tend to do tubes for most of them because you know the tube's going to work. But be cautious about doing big plates in patients with JIA or very severe uveitis from childhood, because they can get into serious problems. And the pole glaucoma implant has actually reduced our threshold for tubes because the early post-operative period is more predictable than what we've had in the past. So don't reduce steroids just to take the pressure out of the equation, or don't reduce the steroids just to reduce the pressure. Operate to take the pressure out of the equation. Thanks for your attention. So it's always a struggle to get through everything to do with uveitis in any short period of time. Minimally invasive bleb surgery is something that's obviously of interest to all of us, especially to those who don't like doing trabs and tubes, because it's kind of a way out, or a potential way out, for those of us who don't like doing laborious procedures that require intensive follow-up. It's still not a perfect alternative, but you've got the Zen and the PreserFlow, which I think everyone knows by now what a Zen looks like. It's been around for more than 10 years. And it does have the potential to give good pressure control and nice blebs. The trouble that we had with the bleb, with the Zen, really was the high rate of dysesthesia and very anterior avascular blebs, which, to my mind, in many patients were worse than mitomycin trab blebs. So you weren't really reducing the risk, and we certainly had a few cases of Zen-related endophthalmitis. And on top of that, Zens, because they're ab interno insertion technique, there is a propensity to get caught in tenons and not drain. And needling became almost routine with Zens. And sometimes it worked. But needling Zens, I must say, was not something that I really ever enjoyed doing. And I always felt it was a bit like feeling the force. You couldn't quite see what you were doing. And there were many cases where, like this, where yes, you can free the Zen, but you've got fairly low chance that you're going to get decent long-term pressure control if you're getting this amount of scarring. And often with needling, and the only fluid that I got was blood. So overall, I was never quite happy with needling Zens, and open revision tended to be a preferred technique. Now, I'm being a little unfair to Zen comparing it with PreserFlow, because PreserFlow is an easy technique as well, except that you've got to open the conjunctiva and apply mito. But I think if we did Zens the same way, we probably would get similar results. But the Zen, and a number of colleagues in the US do Zens ab externo. Now, I've been doing PreserFlow's ab externo, where I've been doing Zens ab interno. And I think the approach has has more effect, more influence than the actual device. And with the PreserFlows, you don't get the limbal avascular blebs, you don't get the dysesthesia, simply because it's a more posterior bleb. And it may be that if you do the Zens the same way, you'd get the same results. This is a speeded up PreserFlow implantation video that I did for Santa, and I've just doubled the speed, otherwise you'll all get very bored. I think most people have probably seen the PreserFlow implantation technique. It's not that difficult. The only thing that actually requires any skill at all is getting the device to sit in the right place in the anterior chamber. And you've got to go in quite carefully and not distort the tissues too much, and get it to lie away from the cornea but not in the iris. And any device that you put through a long tunnel is a little harder to position accurately. But overall, this is a simpler technique than a trabeculectomy. It's quicker. It has fewer variations. There are some tricks. You've got to make sure that the tunnel is formed accurately, or you won't get it into the eye. It's hydrophobic, so you do have to exert some pressure to get it to drain. And you do have to make a clinical judgment as to whether the drainage is appropriate. because no matter what any company tells you, every device that exists has a tolerance. It's a variability in manufacture. And some batches will drain faster than others, and some batches will give you hypotony and others won't. So you've just got to make a call on the table as to whether this is an appropriate amount of drainage or not for your patient. And if it's a patient who's highly myopic, who is very elderly, you might want to consider whether the drainage is too much. But what I've shown here are more typical rates of drainage. You also have to take care when closing not to block the device, and that's why we tend to do quite a large peritomy. It's tempting with a small device to do a very small peritomy, but then you can't actually see where you are when you're closing, and you've really got to make sure it doesn't block. But afterwards, I have to say that pressure flow gives the best blebs of any device that involves any kind of limbal drainage. They're posterior. They don't tend to cause dysesthesia. Yes, we have seen one infection, I think, of blebitis, but it seems to be rare, and these are nice. However, now this is what happens if it's draining too much. You can obviously stent them or put in a ripcord. And this is what I was saying, is you've got to make a call on the table as to whether too much is coming out or not. And putting in a ripcord is a very simple way of preventing over drainage. So you first have to look at the drainage carefully, and I think in this case that's coming out a bit too quickly. That's way, way more than 2 microliters a minute. And if you have a very highly myopic, look at that one. You know, if you've got a very highly myopic patient, or a patient who you think is at any risk from developing a hypotony, a stenting technique where you put a ripcord up the tube that can be removed easily at the slit lamp later gives you a safety net that prevents early hypotony without any serious hassle, other than the fact it takes 5 minutes more in the operating theatre. I've tended to use 9-O-proline because it fits nicely inside the tube. But again, if you've got one that's over draining, you probably find 9-O-proline's adequate. I usually do an anchoring bite close to the tube, and the reason for that is that I had one patient where when I pulled out the ripcord, it actually dislodged the tube, whereas if you've got an anchoring scleral bite, it doesn't dislodge the tube, and it also pulls the tube down towards the sclera a little bit so it's not sticking up. So the anchoring scleral bite's quite a handy adjunct, and best positioned close to the tube aperture. As I mentioned, I tend to use 9-O-proline, but it's not one size fits all. Occasionally you'll find 9-O-proline is tight and only goes in a little bit, in which case I tend to use 10-O-proline. Other people have used 10-O-nylon, which is fine as well. The reason I like proline is that it's a bit stiffer and it doesn't degrade, so if you want to leave the stent in forever or take it out after a year or two, it won't have degraded. Now you can see that 9-O-proline's gone most of the way in, and there's a little bit of drainage, but not too much. So that's just about perfect to my mind. I can't see that that's going to cause hypotony. This one is too tight. You can see there's no drainage at all. So that's not what you want either. So you want to pull it back a little bit and just get a little bit of drainage. There's no point occluding it completely. You're defeating the object. And that's what I mean. And you have to make sure that the eye is well inflated first, because if you've got a soft eye, then it's completely different. Now here you can see the proline was only a tiny bit into the tube. So then you might switch to a 10-O. As I say, I tend to use 10-O-proline, but I use 10-O-nylon here as an example because many people do use 10-O-nylon. As I say, I like the proline because it's stiffer, and also it doesn't degrade, whereas nylon will degrade. Irrespective of the type of ripcord, you've got to be obviously careful that you don't dislodge the tube or dislodge the ripcord when you're closing up. And then you can see the loop post-operatively, And I leave it in the cornea to make it easier to pull out, like a releasable suture. And we wrote up, this was actually a description in Eye a couple of years ago. It was actually, these were for PreserFlow revisions. Originally we used the ripcord when we were revising PreserFlows, but then we started doing it for primary procedures. And the point about the ripcords is, initially when we were only using 0.2 milligrams per mil of mitomycin, hypotony was rare. But it rapidly became apparent with PreserFlows that you've got to use higher doses of mitomycin, and then the risk is higher. So moving to the higher doses of mitomycin, I started using the ripcords. Now, if we look at our registry that I mentioned yesterday, we looked at TRABs versus PreserFlows versus Zens in this. This is an initial analysis that Nathan Kerr's kindly produced. And you can see that the blue, the TRAB, is getting pressures of around 10, whereas the PreserFlows and Zens, it's still pretty reasonable pressure drop, but it's closer to 13 or 14. So if you do really want the lower pressures, you've got to go for the TRABs, although you might note here the TRABs do start with a lower starting pressure, which may actually reflect our clinical preferences, which is to do TRABs in people who might be abnormal pressure glaucoma and need lower target pressures. And in terms of medication, you can see that the TRABs, the Zens and PreserFlows are doing fairly similarly in terms of pressure, but the PreserFlows are doing better in terms of medication, which is interesting. But overall, the TRABs still ahead of the game. So if we looked at the registry PreserFlows, and this was an analysis I did about actually a year and a half ago, and so the numbers are greater now, but I haven't reanalyzed. But if you look at the graphs, the pie charts on the left, the top is a target pressure of 15 or less, the bottom is a target pressure of 12 or less. With lower doses of mito, you're getting 63% below 15, or 15 or less, and 34% to 12 or less. So with low doses of mito, you're not really doing as well as you'd like. If you up the mito doses to 0.4, 0.5 milligrams per mil in sponges, you're getting 78% at 15 or less, which is, reasonable, and 54% getting 12 or less. So that's up to 0.4, 0.5 milligrams per mil of mito in sponges for 2 or 3 minutes. However, if you look at the TRABs in the registry, they're still a way ahead in terms of pressure control compared to Zens or PreserFlows. They're miles ahead. If you want a pressure of less than 21 with a TRAB, you're 99% less likely to achieve it. If you want a pressure of less than 12 with a TRAB, you're still 81% likely to achieve it. And these TRABs, the vast majority, had only 0.2 milligrams per mil of mito, so getting much less mitomycin than the Zens, than the PreserFlows. Much less mitomycin than PreserFlows and much higher success rates. And the PreserFlows, in their turn, were doing better than the Zens. So yes, if you do not have TRABs and tubes in your portfolio and you're stuck with MIGs, then PreserFlow does seem to be the best option. However, like TRABs, my feeling is that PreserFlow is very sensitive to case selection. And I see people telling you that you can do PreserFlows after silicone oil and all sorts of stuff. And personally, I think this is rubbish. My first approach with PreserFlows, I don't do them in black patients, Afro-Caribbeans. We have a lot of Nigerians at Moorfields, and it's very, very difficult to get any subconjunctival MIGs to work in an Afro-Caribbean. And if one fails, don't do the same thing again, which people do, because that's just stupid. Now, in India, I always regard Indian patients as being somewhere in the scarring between the Africans and the Caucasians. In my experience, I get Indian patients who are very high scarring, and I get Indian patients who are very low scarring. Now, how to predict who will do what or how in an Indian patient is difficult. And I think, I don't know, I don't have any scientific basis for this, but anecdotally, I've had more hypotenuse trabs in Indian ladies and more failures in Indian men. And I don't know, it must be more than just gender difference. There must be lifestyle difference or something. And my Indian colleagues can correct me if I'm wrong, but that's just my personal experience, that the subconjunctival MIGS will probably work pretty well in Indian ladies, but I'm not sure about the men. Tanuj, you can throw me out if this is completely, but that's my experience. What do you do if they fail? And this is the question. I've been doing revisions simply because I have a curiosity to know what's going on. Are we out of time yet? Tell me when to stop. I usually dissect the tenons off without breaching the capsule, put on the mitomycin first so it doesn't go into the anterior chamber. Okay, we're out of time now. So I tend to revise them. I tend to open them up, put on mito and close them up again. It's exactly what I did with Zens. The trouble with that is a proportion will fail. And this was 30, this is a report of 36 PreserFlow revisions we did. And we get modest results, but it's probably not as good as taking the thing out and putting in a tube. The question is really, of the PreserFlows that you revise, what proportion will you get away with not doing anything more in? And this is what I don't know. I suspect that it's 50-50, that 50% do okay and the other 50% need a tube. The problem is whenever you revise them and then have to do a tube, you're onto your third conjunctival operation. So then they start getting a lot of scarring and ptosis, and I've had more double visions from tubes that have had previous PreserFlows and PreserFlow revisions than I would do from primary tubes or tubes after trial failure. So there's questions that need to be answered there, and I'm not sure what the answers are. Anyway, thank you very much for your patience and attention.
Thank you, Dr. Keith. I now invite Dr. Kavya Mansoori to give his talk on classic surgery versus mix, how to decide.
Good afternoon, and I'd like to thank Professor Tanuj Dada, the All Indian Society, and APO for the invitation to speak here. I will be discussing mixed versus classic glaucoma surgery and trying to make a bit of sense of how best to decide. These are my disclosures, some of which are relevant to this topic. And while trabeculectomy is still often considered our gold standard, but it's a gold standard that is now about 80 years old, and it assumes a special position, I would say, in ophthalmology and in medicine. It's probably one of the least predictable surgeries in ophthalmology and maybe beyond. And this is because despite perfectly executed surgery, oftentimes you can have a host of early or late postoperative complications, some of which can be quite devastating. And your results are still highly dependent on how the eye reacts to the surgery and how it scars, essentially. In the good old days that were not that good, hopefully not that old, because I was still a resident, our thinking in how to proceed with surgery in glaucoma eyes was quite simple. We would start usually with trabeculectomy, or in some regions, such as mine in Switzerland, we would do non-penetrating glaucoma surgery, deep sclerectomy. When these failed, we would proceed to the next stage, which were glaucoma drainage devices. And when these failed, finally we decided to cyclodestruct the ciliary body. Today, we have more modern options available in the category of mix that provide us often, through an ab-internal approach, a safer, less traumatic IOP reduction, and provide a faster visual recovery and bring the patient faster back to his normal life or work, and can have also socioeconomic positive impacts. Well, a few years ago, when mix were starting, when the evidence on mix was still sparse, there were many questions and discussions about whether they even had any effect in any role to play in glaucoma surgery. Some colleagues refer to them as MEGs, for minimally effective glaucoma surgery. In 2019, 2019, the World Glaucoma Association convened about 100 eminent glaucoma surgeons from all regions of the globe in Melbourne during the World Glaucoma Association's meeting to discuss the topic of updates to glaucoma surgery, and came up with a consensus on glaucoma surgery. And the consensus clearly back then, that's about 5-6 years ago, was that there is growing evidence that minimally invasive glaucoma surgery has a role to play in glaucoma surgery. It is not completely ineffective, but that the evidence available back then was still short-term, usually between 1 to 2 years, and excluded many ethnicities, except Caucasians from the study. So there were many limitations back then, and this has really changed since then, maybe also stimulated by this consensus statement, clearly putting down the limitations of available evidence back then, that many colleagues, many centers, and also manufacturers decided to address these concerns of limited ethnicities, data availability, limited duration of data availability, and also regulatory agencies in many regions in the world, in Europe, in the US, and beyond now, actually demand more than 1 or even more than 3 years of follow-up data to decide if a technique, which often is costly, is also effective and should therefore be reimbursed by approved by regulatory agencies and reimbursed by payers. For all those of you who don't know the consensus, I highly recommend reading it. It is now 5 years old, but it's still relevant to us. The time I have is very limited, so I cannot discuss all the mixed groups, techniques that exist, and this graphic is not even complete because there are so many of them, and some of them come, others go. I'm going to discuss those in red, which are those that I use routinely in my clinical practice, and for whom we have a good body of evidence. The Zen gel stent has been around for about 11 years now. We had a 45 micron size and now the 63 micron size, so a larger lumen size, potentially draining more aqueous and lowering IUP more. It was approved in Europe, in the US, and in many parts of the world. We have 5-year data published for this technique. This is from our group in Lausanne, and this was a prospective study that we initiated in 2015, including also our very first cases where we will still not be on the learning curve, not just in terms of how to do the surgery, but also how to manage it. Also, the manufacturer or the distributor back then really didn't know much about how to best manage postoperative complications, when to do needling, how to do needling. So we were learning ourselves, like other colleagues who were starting on the job, and these data are reflected these limitations are reflected in the data. What you see, nevertheless, despite these limitations, is that almost 50% of data were available after 5 years, so about the response follow-up rate of 50%, and that IUP was significantly reduced from about 21 millimeter mercuries at baseline to the low teens, around 13.5 millimeters, and we have published the data. Needling rates were around 30 to 50%, depending on which patient selection you included here, so high needling rates. Preserve flow, as Professor Barton spoke, came afterwards, goes through a different approach, ab externo versus ab interno for the Zen. The material is a different one, and also the size of the lumen and the size of the implant is a bigger or longer one here. The availability of data in terms of follow-up more limited because the device is more recent, but we have 2-year published data which attest to its efficacy and to its safety, very comparable to the Zen. If you compare the two to each other, you have more data available for the Zen, of course, because of the longevity on the market. There's one single study to my knowledge that compared the two to each other in a retrospective, limited duration fashion, and it found that in terms of IUP reduction, medication reduction, there was no statistically significant difference between the two, and in terms of safety, they were quite similar. There were some differences in terms of postoperative management, for example, the Zen requiring more needlings versus the Preserve flow required more revisions. But globally speaking, in terms of safety or efficacy, there were no significant differences between the two. But this was not a head-to-head prospective randomized controlled trial, which is still what I believe we would need to address the question of which one, if any, is best for glaucoma patients and what would be the risk factors or the predictive factors for success. Going to a different approach, the so-called angle mix. I'm going to discuss three of them here. The iStent, of course, everybody's very familiar with it. It was probably one of the very first mix approved. Therefore, we have a lot of data, some high-quality data available for it, and the mini-inject, the iStent inject, was the latest iteration. 5-year data were published about 2 years ago by Ike Ahmed and colleagues in a study that was randomized, controlled, and compared phaco alone to phaco augmented with iStent. And safety data as well were published at 5 years, which is precious because the question of safety and of endothelial cell safety has become more relevant since the withdrawal of the CyPass due to endothelial cell safety concerns. The study here showed that in terms of endothelial cell loss, the iStent is extremely safe, and they could not find, in fact, any added loss of endothelial cells compared to performing phaco surgery alone. Hydrus is another stent to enhance aqueous outflow through trabecular meshwork into Schlem's canal. Is larger, is a different material, technique is slightly different than the iStent, and also here we have high quality 5-year data from the Horizon study available. This was an even larger study of 556 eyes, and it found that in terms of IOP lowering, there was no significant difference between phaco alone or augmented with Hydrus. However, there was a significant benefit in terms of medication reductions when phaco was augmented by putting in the Hydrus. And there were, over 5 years, fewer secondary glaucoma surgeries required in patients who had a Hydrus added on to their surgery. These are the data of the 5 years. You see that the IOP results look quite similar, and then you have some more detailed breakdown in the table on the right-hand side. What was interesting was the question again of how endothelial cells fare. There were some concerns that because of the larger size of the implant than compared, for example, to the iStent, the fact that a larger portion may be present in the anterior chamber compared again to the iStent, there would be a significant loss of endothelial cells, which, well, depends on how you analyze the data and how you interpret the data that were presented in this paper may be the case. So you can see on those bar graphs that the difference between phaco alone and augmented with Hydrus after 5 years is present. When you look at the numbers themselves, they look, it seems to be a bigger loss. However, that was not statistically significant. However, I would say based on this data, we want to be sure that we place the device really as deep within the Schlem's canal and not have too large a chunk of it be in the anterior chamber. It is a metallic device, and if in contact with endothelial cells, may cause significant damage. One of the interesting studies in this field is an RCT that compares iStent to the Hydrus. 1-year results were published a few years ago. That's the so-called COMPARE study. And it found in a clear manner that in terms of IOP and medication reduction, Hydrus was more effective than iStent. Goniotomy with the KDB is another approach to enhance aqueous outflow through trabecular meshwork by excising a strip of about 100 degrees. It is an elegant method. It requires a simple device which is not very costly, and there is no material left in the eye. And Dorai Raj and colleagues presented recently 6-year results of this technique. It was a retrospective a study limited to 60 eyes, and they looked at KDB alone versus KDB combined with phaco surgery. And they found a success in 46% of eyes. Only 4 eyes out of 90 require secondary surgery intervention. So in terms of reducing the risk of glaucoma surgeries, it was effective. And when you look at the bar charts presented here, you see that there was a significant and actually important reduction in terms of IOP and medications. We know there are different ways to do a goniotomy that may be preferred by some or that may be less costly, and you're familiar with the bank technique or the Tanito microhook. One limitation of all these techniques, going through the ankle and enhancing aqueous outflow through trabecular meshwork, is that there are structures, of course, beyond the Schlem's canal, which have an influence, which may have a very strong influence even on whether these surgeries work and IOP comes down or not. And here we are talking about the location, the density, and the state of collector channels. Unfortunately, we cannot visualize them easily, and definitely not reliably, non-invasively, during our surgery. Alex Wang and colleagues at UCSD have spent significant time studying this question by, for example, inventing a technique called AIOS angiography, where you can intraoperatively visualize those, but these techniques still are not available to every surgeon. You need special instruments and special techniques to do this. However, they have shown that once you can visualize where collector channels are located and decide whether they are in so-called low or high flows, placing your stents according to this location may have a significant effect on your surgery. So these are techniques which we hope will become better, easier, and less invasive in the future and guide us in placing our stents or in performing ablations in a more targeted manner and hopefully improve surgery. We are not there yet. Another way maybe to fully overcome the question of collector channels is to go in different space, which is a supraciliary space. The concept of it is not novel. In fact, it dates from over 100 years ago when a German ophthalmologist, Leopold Heine, published that when you create a cyclodialysis cleft, you lower IUP significantly. The concept back then did not catch on. It was actually very much attacked, and also due to the fact that there were no operative microscopes and definitely not no safe devices, stents or implants to be placed there to keep that space, to open that space in a controlled manner and to keep it open in a controlled manner. The concept clearly was that there is a negative pressure gradient in that space that you create compared to anterior chamber. It sucks in aqueous humor in a more important fashion than any other mixed device could potentially provide. The CyPass showed IUP efficacy, but it also showed bad safety results and was withdrawn. The Mini-Eject, as a successor, has decided to use a more soft material, a silicone material, and to place the stent more posterior. You see the device here, there's a green ring, and the green ring is supposed to be barely visible in the anterior chamber so that the implant itself is far away from corneal endothelium. It can be combined with cataract surgery or done in a standalone manner. It's very similar to the other angle mix. You create an aberrant corneal clear incision, 2.2 size. You go in with your delivery tool and you create a cleft and place it there. 3 pivotal trials were performed, STAR 1, 2, 3. We pulled data from all 3 trials to see the countries and populations where they were performed. Some of them were ethnicities that are usually considered high risk for scarring. And we published the 2-year data in AJO 2 years ago. In essence, IUP reduction was significant, almost 40% after 2 years, with a success rate of almost 90%, 85% of patients having IUPs at or below 18, and 38% of patients being completely medication-free. So these are numbers that are, I would say, better than most mix or all other mix that do not go into supraciliary space demonstrate, again, attesting to the IUP lowering effect of this space. It can be more safety concerning theoretically. We were wondering about rates of hypotony. We were a bit worried by rates of hypotony, I should say. However, we were reassured that hypotony did not seem to be a significant risk here. Sorry for being over time. We have 5-year data now, not published yet, where we find that this lowering is mostly maintained after 5 years in a limited amount of patients, 47 patients where data were available. And the device seems to remain safe also in terms of ECD loss. We did not find a large ECD loss close to what the CyPass created. Now going back to classic surgery, I'm talking here about trabeculectomy or in our case deep sclerectomy. It is a method that has been out for many years, which is an elegant technique, however it's more invasive. But we know it creates aqueous outflow through different pathways, subconjunctival, but probably also into the supraciliary space and due to the way this surgery is performed. You can combine it with IUP measuring sensors, not yet widely available, and these are benefits. TRAB was compared to Zen in a GPS study, and the results after 1 year showed that TRAB, of course, was more effective, but the difference statistically was actually not there. Zen was non-inferior to TRAB in this one study, which differs from other studies, but this was a controlled randomized study. So to finish, with the data we have available now, how should we proceed? This is my own simplified or much simplified algorithm. First, I would say any glaucoma surgeon should be able to perform several MIGS and standard classic filtering and tube surgery. This is part of what a surgeon in glaucoma should be able to provide, so that he can personalize the surgical technique as much as possible to his patients, of course, dependent on the context, economical context where you practice. In patients who have early to very moderate glaucoma, and where the purpose of surgery is essentially you're doing a phaco, you want to reduce one medication, in that case I would do angular surgery, hoping to reduce maybe the medications pre-existent. In the second step, patients who have more moderate glaucoma, your aim is a bit more ambitious. You want to lower IOP and lower medications. And in that case, I think subconjunctival MIGS are more effective. And finally, if you need to lower IOP to the low teens, which is the case in more advanced glaucoma stages, then I would still opt to choose our classic techniques, trabeculectomy, deep sclerectomy, GDDs, because we know they give you, they have, with a higher likelihood, the lower pressures that you need. Thank you very much.
Thank you so much, Dr. Kaveh Mansouri, for your excellent talk, and you have given us a good idea of how to proceed with the mixed procedures. And now we have our good friend, Dr. Samira. Over to you, Dr. Samira. I wouldn't introduce you in a very lengthy way. You are quite familiar to all of us here. Over to you.
Thank you very much for the kind introduction. So for the next 11.5 minutes, I'm going to take you through some of the complications of trabecular meshwork MIGS. So some of these you've seen before, some of these you've never seen before, but all of them you don't want to see again. It's a video that we've pre-prepared.
Invasive glaucoma surgery, or TM MIGS, has been the latest buzzword in glaucoma surgery. These innovative procedures have revolutionized the management of glaucoma, offering patients safer and less invasive options compared to traditional surgeries. However, as with any medical advancement, MIGS is not without its challenges. In this presentation, we will explore the
It was working before.
Settings, if it is in extended mode, you have to present in the mirror. Screen. Display. Mirror.
Okay. Is it that? Yes. Okay, brilliant. Let's try that then. Sorry about that. Let me start again.
Trabecular meshwork minimally invasive glaucoma surgery, or TM MIGS, has been the latest buzzword in glaucoma surgery. These innovative procedures have revolutionized the management of glaucoma, offering patients safer and less invasive options compared to traditional surgeries. However, as with any medical advancement, MIGS is not without its challenges. In this presentation, we will explore the potential complications associated with MIGS, providing a comprehensive overview to better understand the risks and how they can be managed. Here are my financial disclosures. TM MIGS share many similarities and are often more effective when combined with phacoemulsification. These devices are commonly marketed to both cataract and glaucoma surgeons. While a primary challenge is that scarring and failure in the trabecular meshwork cannot be modified, there are notable advantages. TM MIGS do not cause hypotony as they are limited by episcleral venous pressure. They also do not compromise the success of future trabeculectomy and boast a significantly better safety profile compared to any open surgery or MIGS that drain into other areas. The complication rates for these devices are generally low, especially with the iStent and Hydrus. However, complications can still occur. I will provide a brief overview of some of the more significant complications I've encountered, along with strategies for managing and preventing these in the future. Here we have a Descemet's membrane detachment caused during a Hydrus implant insertion. It is a rare complication in MIGS. Of 25 eyes analyzed by Kazarunian et al., there was only one case of peripheral Descemet's membrane detachment. Similarly, Kilman et al. Reported 2 cases out of 54 eyes studied. A strategic approach to managing Descemet's detachment is to introduce an air bubble into the anterior chamber. This technique utilizes surface tension to gently maneuver the membrane back into place. Care must be taken to ensure the air bubble is approximately half its final size to minimize the risk of IOP spikes while monitoring for potential blood accumulation. Peripheral anterior sine K formation is a recognized complication following TM MIGS. Its occurrence at the inlet rather than the 3 windows indicates a more pronounced role of the inlet in drainage. PAS is notably more prevalent in angle closure amongst TM MIGS procedures. Rao et al. Studied the PAS and TM scarring after microincision trabeculectomy and GATT using AIOS2025-GP108-AIOS. They reported that severe scarring was seen in more than 65% of GATT eyes compared to only 31% of MIT eyes, and that the trench pattern of scarring seemed to predict the need for medications for IOP control. Moreover, post-operative PAS in 1 to 2 quadrants in the nasal incised region was seen in 12 MIT eyes and 16 eyes with GATT, while PAS in more than 2 quadrants was seen only in 6 eyes after GATT. PAS formation, of course, can also reduce efficacy, particularly following GATT. Endothelial cell loss is another complication in MIGS. Following the landmark COMPASS XD study, the CyPass microstent was withdrawn from the market due to significant ECL, endothelial cell loss, compared to the cataract surgery group. Conversely, there was no significant differences in ECL between the phaco-eye stent and phaco-hydrous implants and their cataract surgery-only control groups. According to Ahmed et al., mean percentage decrease in ECL at 60 months was 14.3%, plus minus 13.4% in the eye stent inject group, and 14.8% plus minus 10.3% in the cataract surgery alone group. Similarly, according to Fia et al., hydrous implantation showed changes in endothelial parameters comparable to those seen with cataract surgery alone. The higher ECL absorbed with CyPass microstent compared to eye stent and hydrous implants can be attributed to their anatomical positioning within the eye's angle. The CyPass microstent, located in the supraciliary space, follows the curvature of the inner sclera, placing it closer to the peripheral cornea. This vertical orientation increases the risk of contact with the corneal endothelium, potentially causing mechanical trauma and therefore higher ECL. In contrast, eye stent and hydrous implants are inserted within the Schlemm's canal, with the eye stent's short nozzle protruding further from the endothelium, and the hydrous microstent lies parallel to the iris, continuing into the canal. These positions keep them further from the cornea, reducing the risk of endothelial damage and contributing to lower ECL compared to the CyPass microstent. Another potential complication in MIGS is implant dislodgement. For instance, in a video, a hydrous implant is seen diving down, a situation commonly encountered by surgeons. If the implant fails to stay in its intended position, it can cause discomfort and functional issues such as eye overpressurization or canal compression. Repositioning or removal may be necessary to prevent further complications from the dislodgement. Repositioning involves carefully grasping and reinserting the hydrous to ensure it functions properly and remains correctly positioned within the canal. Iridodialysis is a rare but significant complication that can occur during MIGS procedures. It involves the detachment of the iris from its root at the ciliary body, resulting in abnormal iris positioning, irregular pupil shape, changes in iris dynamics, and potential visual disturbances. In the Horizon study, which compared cataract surgery with the implantation of a Schlemm canal microstent versus cataract surgery alone, one case of iridodialysis was reported among 369 eyes after hydrous implantation. This complication can be challenging to manage, as demonstrated in this video, where iridodialysis occurred during the placement of a hydrous implant following a particularly difficult phacoemulsification. The patient's significant movement during surgery contributed to approximately 40% iris detachment, albeit with minimal bleeding. To address this complication, 2 Hoffman pockets were created and 10 zero-proline sutures were carefully used to reattach the iris. Postoperatively, the iris achieved a near normal appearance, highlighting the successful management of this challenging scenario. Transitioning to complications associated with eye stents, achieving precise placement of eye stents is crucial for efficacy. Initial insertions may induce apprehension, but proper technique ensures accurate placement and function. During training, assisting with gonu lens placement can enhance confidence. Care must be taken during subsequent insertions to prevent corneal striae and injector tilt, which can hinder correct delivery. Instances of over-insertion or bias can compromise device performance, requiring careful adjustment for optimal positioning within the trabecular meshwork to ensure effective drainage. Improper placement may lead to dislodgement, necessitating repositioning using a blade or the injector, with options for intraocular or extracorporeal reloading. In this context, intraocular reloading was employed. Caution is advised with eye stent inject due to the limited foreshot capacity per procedure, emphasizing the need for judicious use. The GTW model's larger flange helps mitigate risks of overinsertion, while the eye stent infinite allows unlimited reloading attempts, facilitating optimal repositioning without shot limits. A phenomenon known as pinball visit occurs when an improperly inserted eye stent detaches and moves within the eye. This requires precise retrieval under gonioscopic guidance using Kawai forceps, followed by rethreading and reinsertion to restore proper function. In another case, an eye stent became lodged behind the IOL. It was carefully rethreaded and reinserted into the correct position. When dealing with superficial insertions, a trocar can be utilized to stabilize the stent into a more secure position. Care should be taken to avoid placing irrigation aspiration tools too close to the eye stents to prevent displacement or disruption. Hyphema is a common occurrence in TM MIGS procedures, with wide variability in its incidence across studies. For example, Seek et al. Found that 17% of the eyes experienced transient hyphema in their study, comparing standalone KDB and combined KDB with cataract surgery. In another study by Fellini et al., hyphema was identified as the most common complication, with incidences of 3% in the KDB group and 14% in the trabectome group. Fortunately, hyphema is typically self-limiting without significant clinical implications. However, larger hyphemas may require evacuation, especially if there's an associated risk of elevated IOP or corneal staining. Trabectome procedures may lead to more frequent hemorrhage and long-term intermittent hyphema due to their larger drainage area. The iridodialysis observed here was caused by the KDB procedure, emphasizing the necessity of maintaining a clear surgical field. This condition can result from applying excessive downward force during the procedure, while excessive upward force may lead to descemet membrane detachment. However, such complications typically do not require repair unless they are severe. In conclusion, although complications are a natural part of learning TM MIGS, proficient management skills are essential for handling various devices. Ensuring thorough patient education and adhering to best practices without taking shortcuts are key to achieving optimal outcomes. Setting realistic expectations and striving to exceed them is crucial to patient satisfaction.
Thank you very much.
Thank you, Dr. Shamira. Wonderful presentation, taking out each aspects of the complications one can see during the surgery. Now we move to the last presentation, MIGS, truth versus hype. by Dr. Sanjay Asrani.
Thank you very much for your patience. Good afternoon. I know this is a post-lunch slumber, so I'm going to try and give you some of my thoughts on this topic, and I implore you not to shoot the messenger. I'm a recovering MIGS addict. MIGS really works well especially when there is no glaucoma. I truly wish all MIGS would work. Except for canal surgery, everything else is trying to do a better trabeculectomy, basically creating a better bleb. I'm trying to get away from becoming a blebologist, and the MIGS surgeries are driving me back towards becoming a blebologist. Why is trabeculectomy still the surgery of choice in moderate to advanced glaucoma and worldwide? And cataract surgery, remember, is the best glaucoma surgery there is for the vision improvement, the pressure drop, and the least amount of complications. Why did MIGS evolve? Post-op care is not adequately reimbursed by US insurance. There is unpredictability in post-op and outcome. Believing that majority of the resistance in the outflow pathway resides in the trabecular meshwork. Yes, these were based on the experiments done by Morton Grant. And he had implored everyone that it needs to be repeated because he had done it only in less than 5 eyes with a regular microscope. Also, with glaucoma surgery, you get poorer visual outcomes, and the patient says, "You did glaucoma surgery, but I can't see any better." One must remember that aqueous causes subconjunctival fibrosis. Is because of that we are needling after Zen. It is not the conjunctival handling, because if the Zen is being done ab interno, there is no conjunctival handling, but there is still tremendous fibrosis. How much more predictable has Zen allowed a trabeculectomy to become? Are we such poor trab flap creators that we cannot create a flap enough to control hypotony? So now we are deciding to put the Zen ab externo. Putting in a preserve flow. Material is SIBS. Does it matter? It's not the material that matters. The material prevents fibrosis, but it's not the material that causes the fibrosis. It's the aqueous that it is shunting that causes the fibrosis. Its strength is that it pushes the bleb posterior to the limbus, but it still suffers from the fact that there is an inciting element that is aqueous. But needlings can become more difficult because the bleb is now further posterior. The Horizon study that you already heard today, although the primary goal for MIGS surgeons is often to reduce medication burden, mean pressure reduction of about 2, the mean number of reduction in medications is about 0.4 at 2 years. MIGS can reduce the need for secondary glaucoma surgeries by about 1.8 to 2.5 over cataract surgery alone. I want to point out the small percentages that you are seeing on this slide. And as Professor Kaveh Mansouri has published in this paper, The Current Opinion in Ophthalmology, in 2024, while traditional surgeries offer robust IOP reduction, MIGS offer better safety profiles and fewer complications, more predictable refractive results. While MIGS have demonstrated promise in decreasing reliance on medicine, the quality of the evidence varies among the studies. There is a pressing need for additional high-quality, independently funded comparative studies to evaluate MIGS, efficacy, safety, and cost-effectiveness. And I'll come to that in my second last slide once again. Combining MIGS with phaco in open-angle glaucoma, a meta-analysis. This was published in 2024. Based on the current peer-reviewed articles, there is evidence when compared to phaco alone, combined MIGS and phaco is beneficial for POAG and does not increase the incidence of vision-threatening events. The key limitations is the heterogeneities in the protocol design and the limited number of high-quality studies with long-term follow-up. This is again another study from 2024. Adding a MIGS procedure to cataract surgery provided an additional 1.6 to 2.3 millimeters of mercury reduction in subjects with mild to moderate glaucoma at 2 years. The cataract surgery alone provided 5.4 to 7.6 millimeters of mercury reduction. This is a statement by the American Academy of Ophthalmology. In other words, adding a MIGS procedure provided only 3.8 to 8.9% IOP reduction over cataract surgery alone, which provided 21 to 28% reduction. One may approximate that cataract surgery alone has the potential to possibly eliminate 0.8 to 1 glaucoma medication, and that adding MIGS may have a mean reduction of medications by 0.4. That same article, it is important to highlight that all clinical trials on MIGS procedures were industry-sponsored and then thus subject to potential industry sponsorship bias. In addition, nearly all had first or corresponding authors who had financial interests in those specific companies. On multiple occasions, the authors, investigators had stock options or were owners of the company, consultants, or direct company employees. Are these procedures as benign as they are supposed to be? Well, let's look at some ocular complications within 90 days of the index procedure, XEN compared to goniotomy and canaloplasty. Look at the endophthalmitis, 6 in XEN, 8 in goniotomy and canaloplasty. Malignant glaucoma, 5 in goniotomy and canaloplasty. Vitreous hemorrhage, 11 and 69. That's pretty surprising. And this is from the IRIS database. This was another study that came and went and nobody paid any attention to it. It is the endophthalmitis after MIGS surgeries. 9 cases of endophthalmitis was associated with the eye stent, 3 with the gel stent, and 1 with CyPass. No cases were associated with MIGS that had no implantable device. Endophthalmitis after MIGS may be of similar frequency when compared to cataract surgery alone, but with potentially more virulent organisms. Ultimately, the incision is the biggest risk factor for infection. This study looked at cost effectiveness of trabeculectomy versus the micro shunt in the US Medicare system. Even when the micro shunt device is free, the procedure remains dominated compared with trabeculectomy, which continues for 20 years into the future. There is these modeling things that we can do called willingness to pay threshold of $50,000. The microshunt's likelihood of being cost effective is only 6%. trabeculectomy had higher efficacy and lower cost in 78 of the 1,000 iterations of the Monte Carlo simulation. As you can see, the MIGS procedures are just not cost effective compared to the benefits that they provide. Reporting clinical endpoints. This is from this year's paper. At 2 years, once again, it is shown that cataract surgery alone is giving you 20% or more reduction. The mean number of medication decrease, again, about 1 medication. The recommended minimal clinical effective cumulative probability of surgical success is 65%. Combined cataract and MIGS should provide meaningful reduction than cataract surgery alone. So the surgical success for standalone MIGS, as defined by this paper, is 21 millimeters or less of mercury, along with reduction of 20% or more from baseline, without increasing glaucoma medications, without additional laser, incisional surgery, or loss of light perception. And surgical success for MIGS with cataract is all the above, along with a decrease in medication of 1 from baseline. So that means if you do cataract combined with MIGS and you reduce 1 glaucoma medication, it's considered a success. But wait a minute, with cataract surgery alone, you can reduce 1 medication. So what is MIGS adding as a benefit? This paper is literally hot off the press. This is published in April issue of Ophthalmology Glaucoma. 2,770 ophthalmologists were paid $41 million between 2016 and 2021. 273 were glaucoma specialists. Well, that tells you how many glaucoma specialists are adopting this. Only 10%. 390 of this entire cohort were paid $27.7 million. They were called high rollers. These high rollers received payments for consulting and speaking fees and were more likely to be actually glaucoma specialists. This was excluding travel. The odds of high MIGS utilization increased for increasing amounts of payment, indicating that the companies anticipate greater return from their investment in high rollers. Those who received payments from the companies were more likely to perform the higher number of MIGS. So how did I decide to overcome this MIGS addiction? That's what you really need to know. Learn how to do a predictable SLT laser. Now that the IOP is controlled off 1 medication, there is no need for MIGS. Do it 360 degrees, titrate it, correctly identify the TM, don't treat Schwalbe's line or ciliary body, and don't use post-SLT steroids or NSAIDs. Identify intermittent angle closure in time. Intermittent iris touch of the TM worsens glaucoma. Learn to better post-op management of trabeculectomies, intense steroids, steroids for life, release sutures in time, aqueous suppression if there is cystic nature, and learn to evaluate the microcysts on the surface of the bleb. Thank you very much for not shooting the messenger.
Thank you, Sanjay. I think we'll have to provide you some security when you visit the trade exhibition. So, Keith, some remarks from you?
Sandy, not shooting the messenger sounds very poor excuse for... saying not shoot the messenger is a very poor excuse to disclaim responsibility for what you've just said. Yeah, you got to have more balls than that.
I'm not recipient of the $30 million that was.
Okay, so what you said is absolutely right, except that the fact that that the big trials are industry sponsored is probably irrelevant, because if you actually look at the results, they all show that MIGs hardly do anything. So it doesn't matter who's sponsoring them. The point is that the outcomes have been manipulated to look good, and the biggest culprit is the FDA, because they've accepted crappy outcomes and licensed things that hardly do anything. If you look at the COMPARE study, industry-sponsored, multi-center, prospective, comparative study of the two best devices at the time, and shows that both of them hardly do anything. You know, it's hard to get away from the fact that the Hydrus produces an 8.9% pressure drop and the iStent a 5.5% pressure drop. Those are industry-sponsored, multi-center randomized clinical trials from the greatest experts being paid $42 million, and they still don't hardly do anything. I mean, how do you then, what does it matter what bunch of cases people independently publish after that? You've got the fundamental studies that, and the Horizon study accepted by the FDA on the basis of this, you know, well, so many people get a 20% pressure drop. I mean, it's like nothing. In the Horizon study at 5 years, the difference between phaco and phaco hydrous was 1 millimeter of mercury. And as you rightly said, 0.4 medications. It's nothing. The majority of it is cataract surgery. It's an enormous amount of smoke and mirrors. The one thing I would say is, though, don't tell people that cataract surgery is great, because that's all they ever do now.
Kaveh, would you
anyway,
like to
great talk otherwise.
Thank you, thank you.
Kaveh, would you like to give some closing comments?
Well, closing comments on a wide range of topics and discussions won't be easy here, but just to build on what was said, it's a difficult discussion on mix, and yes, you know, on average it may be 20%. I think it shows the limitations we have to determine which patients specifically will benefit from which mix and others that will not have maybe even zero effect added to cataract. So we know averages, you know, reflect some cases that didn't work at all and others that worked actually very well. And this is the case. All of us who do mix know that some patients do have very good results on mix while others have zero. The work that, you know, colleagues such as Alex Huang, who's actually in the audience, do to visualize, you know, the anatomic system, this type of work will hopefully help us in the future to determine who may benefit and who may not, thereby helping saving costs for unnecessary stents or techniques that some patients may not need. So we are still at the beginning of the road to improve glaucoma surgery through newer, better, less invasive techniques, but we are not there yet.
Thank you.
Yeah, one of the things that was taught by my former chairman, David Epstein, was that he had worked with Martin Grant. Martin Grant had done the surgical removal of the trabecular meshwork and found that there was improvement in the resistance. But he was constantly reminding us, don't forget that there is this collector channel system, and downstream that gets fibrosed, and you may not be able to open it. So even if you take out the trabecular meshwork, so what? Now you have eliminated the possibility of that patient getting any stem cell therapy in the future for trabecular meshworks. The other thing to remember is that it was Rand Allingham, my teacher, who was the first one to identify that Schlemm's canalis collapsed in glaucoma. And he was the one to propose that stenting it might improve the glaucoma control. But it has to be stented at least 270 degrees. And even then, you'll reduce the resistance partially, not entirely.
Can I just, sorry, very brief comment. I think when Ike Am and Tom Samuelson were originally working in the Hydrus, they did have much, much longer stents. And apparently it caused very high pressures, which is why they had to shorten it. Apparently the original Hydrus, they tried various lengths, and apparently they got ballistic pressure rises from the longer one. So so stenting it further doesn't seem to work well either. But
so Sanjay, does SLT adversely impact outcomes of trabecular MIGS?
I don't think so. And I think there have been some papers recently that have published that SLT does not. In fact, they've been trying to look at the response to SLT to predict who would be a better candidate for trabecular MIGS. And again, they have not been able to identify who. So that is a...
Yeah, there's a big iris registry study last year in one of the big in ophthalmology, looking at SLT on ab internal canal MIGS, and it suggested that those that had SLT first did worse, but that surely must reflect case selection. I can't believe it's actually anything other than that.
That's right.
I think we have one question from Swati.
Sir, excellent talks by everybody, but yes, Dr. Asrani, you opened a hot
Pandora's
topic.
box, I think.
Yes. So, sir, I wanted to ask, we didn't have SLT before, now we have SLT. So, what are the patients whom we should not try SLT on? Like the patient is on prostaglandin analog, beta blocker, brimonidine, like 4 medications. Are they good candidates, or we will get good results if we do SLT in these patients now after say 4 years, 5 years of medications?
You're absolutely right. After patient has already been on multiple medications, the trabecular meshwork functioning is very poor. That is why they needed that many number of medications.
Correct, sir.
Stimulating that kind of a trabecular meshwork is not going to work. And that has been shown previously, that if it's used as last line, it is best used as first or second line when you can stimulate the trabecular meshwork and make it work better.
Yeah, I'm sorry, we have to cut short because the next session is due. Dr. Swati, Dr. Sanjay is coming to Bhopal also, so you'll have enough opportunity to grab him. Sir, we can have it just after the session, if you don't mind. Can we have a quick group photograph, please?